Everybody. My name is Kelly Mann, and I'm the Director of Programs with A Time to Heal. Thank you for joining us today. This is a really important topic, and we're really fortunate to have Brier here to present to everybody. I just wanted to start off by thanking our sponsor. All of our Create Your Best Life events are sponsored by Nebraska Cancer Specialists, and including our session today. So Nebraska Cancer Specialists is a proud supporter of A Time to Heal, and together we're committed to providing exceptional care and continued support to patients, families, and caregivers. If you want to know more about Nebraska Cancer Specialists, you can visit their website at nebraskacancer.com. So again, I just want to thank everybody for coming today. Joining us, we have Brier Jirka. Brier is a licensed independent mental health practitioner and certified sex therapist through the American Association of Sex Educators, Counselors, and Therapists. Brier has extensive training in women's health and has been training in women's sexual health for over 13 years, and we're very fortunate to have her with us today. So thank you so much, Brier.
All right, guys, so we ready to talk about sex today? Yes. So I was talking to Kelly about this. Having the past 2 years talk to a computer is sometimes challenging, knowing the fact that I'm a therapist and not a tech person. So we are going to do the best we can with this. See, look at that. Let's see. Kelly, can you still hear me?
Yep, I can hear you just fine.
Perfect. So as Kelly was saying, I have a ton of content to go through, and I just want to make sure that everybody gets what they need out of this. So please, please, please feel free to jump in anytime that you want to. Just let me know. Totally informal. I will fast forward through this as much as I can. There's 56 slides that I'm going to cover in like 45 minutes. I will most likely skip over them pretty quickly, but just want to make sure that everybody has a chance to, oops, that is not what I wanted to do. Questions if they have them. Okay. I hate that I cannot see myself talking right now. Okay. All right. So I have no conflict of interest. I will talk about different.
And Brier, we don't have the slides pulled up if that's what you're thinking is on the screen.
Oh, you do have the slides pulled up?
I do not. I don't see them. So
let me escape that then. That probably would be why you guys are like, what is she talking about?
Thanks, Brier.
See, told you guys, I am a therapist, not a tech person.
Yep, there we go.
Beautiful. Now you guys can know what the heck we're going to talk about. Okay, so as I was kind of saying, I suck at tech, way better at talking about sex. So that's what we're going to do today. As I said, you guys can have access to these slides after the presentation. So don't feel about having to write stuff down. The ones I'm like, oh my gosh, you went too fast. Also, my contact information is going to be at the end. Please feel free to contact me. As Kelly said, I know there's participants from all over. And so some of the resources I have at the end are local, just the fact that's who I work with directly. But being part of ASECT, which is what Kelly mentioned is my certification, is a worldwide organization. And so I do consult and collaborate with people across the country, depending on needs. And if I have clients that move out of state and I'm getting them connected with people. So I definitely can help maybe bridge some gaps for people if you do have an interest in resources in your local area. All right, so again, I have no conflict of interest. We'll talk about things. I don't get any of that. It is being sponsored, so give you a heads up with that. They are supporting me to be here. A little bit about me. I'm from Omaha. I grew up in Nebraska, hate snow. As we were just talking about, we had our first one last night. Reminds me why I moved to Arizona for college. And then I missed the snow and wanted to come home. So moved to Kansas City, did some graduate work, and then said, you know what? Omaha is really missing some sex education, and I want to come home and really plant my foot there, and therefore have really jumped into what is considered sex therapy with a specialty in medical diagnosis. So I specialize in cancer, strokes, TBIs. Predominantly, I only treat women and couples now, but I am certified to treat men as well and do prostate groups and support groups and trainings on those as well. So just to kind of talk about some statistics up front, why this is such a topic that I love when organizations bring up is it is such an under talked about issue in cancer. I get we go to oncologists and we talk about things and we want to save lives. Totally love that the medical community does that. Kind of the most important thing up top. But then what happens is we get into our treatments and we get into back to our lives and then what? We have these ongoing medical, psychological, social issues that tend to be then like there isn't a support for. So I like this thing because it says, that 74% of participants thought addressing this after cancer was important. There are still the social sex differences that 29% of those were breast cancer and 79% were prostate. Goes into the aspect that Viagra got pushed through the FDA after 5,000 trials. The first FDA approved sex medication for women took over 50,000. So big differences in time frame, and money goes to where the research is. So again, I just like some interesting facts to talk about. The one that to me is really gut-wrenching is the very bottom one. 39.5% will be diagnosed with cancer at some time in their lifetime. 40% of individuals in the United States will have some form of cancer in their lifetime. But we're not addressing the after effects of their relationship and their sexuality. The other one we talk about is 68 sex and gender minority women that were diagnosed with breast cancer. Only 25% chose to get reconstructive surgery. So we'll talk about also the vast amount of sexual expression and identities and gender minorities that are coming more forward and being more open with their own identities, that we're seeing a different outcome in some of the choices made for treatments. So reasons why we should care. Why is anybody asked me to talk about this is people are living longer. We have more time on this earth and really want to enjoy it. And we're having a big push in pleasure over performance. It's not just grow up, get a job, do what you do, retire, die. Like there's much more life to live. And we're more pleasure and sexual expression focused, which is a huge thing for us as sex therapists, is to move from performance sex, which is a lot of the questioning talks about, my desire is not there, or my orgasms are broken, or I'm having this pain. Yes, those are the actual physical components of sexuality that performance is not working, that we want to say, hey, we can make sex not so painful, but where can we seek more pleasure? So most important sex organ is your brain, which I have two of because I think they're fun. Sex is 80% mental. And people are like, well, Brier, I 80% hurt during sex. Totally understand that. I don't ever want to not validate that with individuals. The aspect is, from my job with my collaborative teams that I work with, which are the doctors, the nurses, the social workers, the pelvic floor physical therapist, anybody who's part of that overall person identity, the brain is a huge component of how do we reconnect things. Think of a marathon runner who hurts themselves in a race, but still finishes their race because their brain and body are so disconnected and disassociated. They don't connect it. The second they cross that finish line, everything comes flooding in. So when we have pain with sex or physical ailments in our body, and we reinforce over and over and over every time we go to have sex, we are depressed, we have pain, we have discomfort. We reinforce that over and over and over. And my job is to kind of help, well, let's stop this connection for a short time and rewire things to perceive things differently. Largest sex organ is your skin, tip of your head to the tip of your toes. Sex, we tend to think sexual organs, we tend to think breast, we tend to think buttocks, we tend to think vagina, these lovely big sexual pieces, but you have nerve endings from here all the way down. We really want to focus on those other nerve endings that can get fired while we're still healing the ones that were damaged during the treatments. So again, these are the two slides I'm going to really, really go through fast, because again, those of you again that are here, I've never had cancer. I tell clients all the time, I don't know what it's like to be a cancer survivor. I am just a clinician who is trained in it. So these things, I don't need to tell you are happening because you're living them. So therefore, I just like them in a list to be able to say, like, yeah, this is impactful. And we really do need to pay attention to all these different areas that are being affected. So again, what you'll see between the two slides when you get them printed out at your own space is they're very, very, very common between men and women. Same kind of changes happens in different parts. So again, I know 2012 sounds like it was a million years ago, but what I like about this significant research is it says that using Viagra prior and during treatment actually can help with erectile functioning after post-surgery. So again, we see improvements, and then radiation, sometimes we see more decline, because as we know, radiation's in the body, it tends to stick and we see more long-term effects. First surgery, we tend to see erectile dysfunction get better over time. But Viagra, we saw, if taken during and before, had an even better effect, which is great. A lot of the questions relate to this. I hear this every single day when I deal with patients with cancer, specifically breast and prostate specifically, for the fact that you look different, you feel different. So the number one complaint we see is body image with most of our cancers. So the big one we talked about is breast surgery. So when it comes up the most culturally normed, we tend to feel different. There's different sensations. There was a question about feeling numb and that not being able to enjoy your partner's touch and not be able to feel that anymore. And partners sometimes will not touch that area. They'll completely skip either the penis or the breast, thinking they're going to trigger something painful in you, or that, well, they can't feel anything anyway, I won't touch it. And it's like, that's not what we want to do. We really want to work with that individual and that couple to talk about, what is that experience? We'll talk about grief here in a second, of we need to grieve those previous experiences. Anybody open to talking about that experience of feeling so different? If not, totally fine. It's one of those things that there's just such an identity shift that we don't really give enough credit to prior to these procedures. And I talked to a lot of oncology and oncologists about really needing to just talk about this in more detail prior to these like procedures, because you wake up and you're not the same. The person is, but the identity that you carry physically and sexually is not. So again, we really work with couples on redefining themselves as a sexual person and parts of their body, but also grieving that you did lose a large portion of your sexual self and really validating that. So again, we talk about, especially even with prostate cancer, there is so much of a nerve bundling issue. We know with technology, this is getting better and better and better, but we still see a lot of those long-term effects of erectile functioning, either with erections or ejaculation. And again, it's back to normalizing and validating, this is not okay. This doesn't feel okay. What can we do to help rewire those connections, as well as find different forms of stimulation to kind of help that body reconnect as much as possible? Grief. I could talk to you all day about this related to cancer and sex. We, again, really don't give it enough credit. And the big one we don't talk about the most is the anger. A lot of people think, oh, it's sad, like, cancer's sad. No, cancer is, pardon my language, kind of bullshit angry. Like, you're allowed to be pissed and frustrated and angry. Psychologically, we don't want you to stay there forever, because you really won't be able to live and really experience the newness that can come. It just will be different. It's not going to be the same. That doesn't mean it's going to be worse. The psychological changes, again, with my area as a mental health practitioner, these are the things we really push about discussing: the depression, the anxiety, the grief, the loss of self-confidence. As a sexual person, you might find yourself more timid to engage in sexual activity or even talk to your partner. Being incomplete or feeling like a fraud. I used to be this really sexually powerful, person, and now I don't have that. And so if I have sex, I don't feel like I'm being genuine to self. Again, we talked about less attractive, less feminine or masculine. We're labeled as cancer survivors. We're supposed to be these cancer warriors, and we live, so we're supposed to be okay. Nope, you don't have to be okay. It's okay not to be okay. There's just an acceptance that, yes, you're a cancer survivor, but we also need to work on what does that look like post-treatment. So again, we talk about depression. A lot of people are put on these days on depression medication, which will affect a lot of sexual functioning. Even if you're not a cancer survivor, being on antidepressants, anti-anxiety meds tend to have negative effects on sexual libido, arousal, and orgasm. So it's just something to kind of talk about, that being depressed isn't going to help you feel sexual either, but the medication may also affect the physical aspects on top of some of the other things going on. Vaginal pain, as somebody that my specialty, again, is treating more women's sexual health, I work collaboratively, like I said, with a team of doctors, nurses, PF, pelvic floor physical therapists, and we meet once a week to go over patient care. Dilators are what that picture is, and dilators are used for vaginal stretching slowly and slowly and slowly, almost like if you were to bend down and touch your knee and then go a little further and go a little further until we get that tissue and muscle to stretch. But again, a lot of the times there's so much tissue damage and dryness that feels like, Brier, I could never use dilators right now. And no, but there are exercises to do that are not internal. We do talk about Premarin, but again, I know a lot of the questions were my cancer's hormone positive, and so I can't use any form of estrogen or hormones. Absolutely can agree with that. You know, we'll talk a little bit about that controversy here in a minute, but just to know that these are some options when we have that vaginal pain. Vaginal suppositories, a lot of my medical specialists will use those to kind of help relax that internal muscle, just like you would taking a Valium for, you know, going in for an eye procedure or some other type of surgery. Erectile pain, so we talk about Peyronie's. So this is a curvature of the penis that can happen with that tissue damage. And actually pelvic floor physical therapists can also treat this. A lot of men don't know. They think, oh, pelvic floor physical therapist is only for women, but they're really trained, at least some of them, in treating Peyronie's very well. I've had plenty of my PFPTs here in Omaha do really well work with this. So we also talk about the penile shrinkage that can happen. It's kind of the mentality of the nerves are actually, again, they're kind of shocked during these treatments, and we don't know the exact cause, but we do tend to see those changes in some men up to 6 months post-procedures. Like I said, pelvic floor physical therapists, these are specialized physical therapists that work with that definite, what we call the bowl that holds up all of our internal system. This is both men and women. So they're good for like urinary issues and incontinence issues that can happen, as well as just, I think, helping your head connect back to your body. So as a physical therapist is either treating those muscles directly or helping you connect back to them, you as yourself can gain more confidence in your body, just understanding how it's functioning on a different level. Also, the pelvic floor is what contracts during orgasm for both men and women. So if your pelvic floor is damaged from any form of treatment or just not working the way we want it to, this will actually help with orgasm completion or function or increase if our pelvic floor is functioning at the best level. So how do we imagine or manage a colostomy bag? So again, don't think this sounds very sexy when we have a bag hanging off the side of our body. Many clients I've worked with, you know, that finding a sense of humor, number two, is hard when, like we said, we're still in maybe that anger stage or that denial stage of grief. But as we can accept that and say to ourselves, I want a sex life. I want a sex life. These are the things we can do to remove some of those tangible, like in your face visuals that might take away from sexual libido. Timing is a big one. There are now gorgeous pouch covers that can be used. Talking to your providers about what are maybe the best time of medications and things to use, placements, activities of eat. This is where structured sex is talked about a lot for clients who've had cancer treatments, strokes, my TBIs, due to the medical treatments that come with that. We want to kind of identify that we might have to take some time to like empty a bag before or do some pelvic floor stretching prior to, you know, an attempted intercourse or sexual play. We might have to apply some lidocaine cream to the vaginal tissues for 15 minutes prior to touch. And everybody's like, well, that sucks. That's not what I want to do sexually. It's not what I like. Yes, this is part of the, I don't have to agree with it, but the acceptance is that's how my body's functioning right now. And if we can get to that negotiation in our head that this is where it is right now, you're probably going to have more enjoyment being able to see the options that are open to that you weren't to before. So yeah, go ahead.
I did receive a question about a couple slides back about the vaginal suppositories. It says, what type or brand of vaginal suppositories are used to help with pain that you mentioned? And it says that you related it to giving a pain reliever before an eye exam.
Yep. So vaginal suppositories are going to be given by your medical provider. They are prescribed. They're not over the counter. My Dr. Anna Maria Nagy, who I work with here in Omaha, is a specialist in menopause and treating sexual pain disorders. And basically patients who are having, you know, we talk about tissues versus muscles. And so we tend to treat tissues on the outside. So as that estrogen's deprived, those tissues become brittle, and that's where things get really scratchy and uncomfortable on the outside to penetrate. But those muscles on the inside also don't have that flexibility. And so if we can get those, they almost look like a little bigger than Tic Tacs, but look almost like teardrop shaped, can be inserted, and basically they dissolve into those muscles. And so it just causes that muscle to relax. Like I said, almost like an oral Valium or Xanax would for an overall body. These are strictly done internally to those muscles. So again, they would have to be had and received from a medical provider. So, but once they're shown how to be inserted in the office, they are absolutely something you can pick up at your pharmacy and brought home and used as prescribed. So I hope that answered that question.
Thanks, Brier.
Yeah, no worries. And great question, because again, the difference with a lot of sexual medicine is there's so many things. If you were to Google right now, sexual medicine treatments, you're going to get a plethora of stuff. And we always say even Googling sex is dangerous because who knows what's going to show up on your laptop. The reality is, though, that we want to discuss what options there are, both that you need to go to a medical provider and that you can naturally seek on your own over the counter or through natural remedies, because we are also living in a society that is balanced between really being wanting to be holistic and that very based, nope, Western medicine, I want a pill for it, I want a diagnosis for it, fix it. These kind of can come together really nicely. So again,
I have a question. Sorry.
Oh, go ahead.
Back on that slide, it says that those contain estrogen.
Mhm.
Or for the ones that like me, I can't have any products that have hormones because my cancer is fed by hormones or was fed by hormones, and I'm BRCA2 positive.
Yep.
So what will be the alternative to those?
The Premarin cream and like the estradiol and things like that, that would treat vaginal dryness and some of those pain symptoms absolutely have estrogen in them. The vaginal suppositories do not. They are not estrogen or hormonal based. They are strictly, like I said, almost like a pain medication or a muscle relaxer. So they are used quite often with our clients that absolutely cannot have hormones or have decided that they don't want them. This is where I said the controversy can come in. And I know there was a question about DHEA that does have an estrogen effect. Plus some of the medications I'll talk about later, like Osphena, was meant for vaginal pain, but not studied in breast cancer specifically, but says it's hormone-like. And so therefore they still don't recommend it for anybody who has hormone positive cancers. It's a tough space to be in because we know with estrogen, the body can't replace it or anything 100% like it. So it is that acceptance that no matter what we find, won't probably ever be exactly like it was, but can we do something to treat those individual pieces? Can we put something on the vaginal tissue that might help it be less sensitive? Can we use a suppository to help those muscles relax? Can we use PFPT to help connect? Can we use sex therapy to help redefine? So it feels like a lot of work, but when they start flowing together, they do flow very beautifully. But again, it's like trial and error and trying to find the right combination at the right time and where you're at in treatment and where you are in your lives that really works. So yes, absolutely good question. I should probably separate that, but yes, the vaginal suppositories don't have hormones in them. Did that answer your question? I hope.
Yes, thank you.
No problem. So like I said, I tend to use a lot of humor. I make a joke that my initials are BJ and my last name is Jirka and I'm a sex therapist. It's just very odd and awkward. But the reality is that cancer is not funny. But if we don't get back a self-identity and some of that is a sense of self, we're going to be a pretty miserable society. And so also, a lot of sex jokes are very heterosexual focused and very much that men are always horny and women are not. And that's not true either. We are seeing a huge increase in women's sexuality and being more open to, nope, I want to be a sexual person. Flip side, when I have males that I've worked with who are having sexual difficulties psychologically or physically, society's like, oh, you should be fine. You should always be horny. And it's like, well, no, that's not always how it works either. So this slide just gives a very big example of what that looks like. So what are the things that we use? And we're going to go talk about these pretty quickly too. So this one I like is that, oh, that pill that was advertised. I'm not sure what it is, but I want it. Everybody wants a quick fix. Doesn't matter what the diagnosis is, doesn't matter what we're treating. Everybody wants it to go away quickly because why would we want to sit in discomfort? Why would we want to sit in pain? So this is just, again, an example of our social societal norm of like, I go in, I want it done, and I want it fixed now. So lubricants, there are gazillions of them. If you've ever walked into any store, Walgreens, CVS, Hy-Vees, grocery stores, Piggly Wigglies, wherever the part of the country you live in, lubricants, there's whole shelves of them. And you turn over the back of them and you can't pronounce 90% of the ingredients in them. So it's funny, I tell clients all the time, people spend hours looking at labels for their food and what they're going to put, but people put anything in their vaginas or put on their penises. that you have no idea actually what's in it. So I'm an advocate of just know what we're putting on our body, because sometimes if you have those sensitive tissues from, estrogen depletion, that certain lubricants will actually trigger not good sensations, such as things that heat or cool are sometimes really aggravating to the vaginal tissue. And we should really work on staying away from those from a lubricant perspective. Again, things like the olive oils and the coconut oils, we don't suggest using on your really nice bed sheets because it'll stain them. But putting down what we call a sex blanket or play blanket is a way to prevent those sheets from being not so destroyed. Also, that could be where you play in your kitchen instead of your bedroom. We always say to start with maybe a water-based lubricant because it has the least amount of ingredients in it, glycerin versus non-glycerin. And then moving to silicone, which is almost like when you get it on your hands, you can't get it off without washing. Water-based is going to become tacky very quickly, and it can be reactivated by more lubricant or saliva. The reason we talk about lubricants is the difference between lubricants and vaginal moisturizers and hormones, which is another part of the question somebody asked, is lubricants are very topical. It's like if you were to put lotion on your hand, it's that day, your hand feels great. Vaginal moisturizers are, if I'm going to put lotion on every day in small amounts, we might actually get a change in that tissue, both if we were to hydrate water-wise and that vaginal moisturizer, we might help those tissues on a few deeper levels. Estrogen would be all the layers. So clients are like, I could pour a whole bottle of lubricant, Brier, and it still feels scratchy. And I'm like, well, that's because you're only treating the topical layer. So if I go home and put an entire bottle of Lubriderm on my hand, it's going to be no different if I put a small amount and rubbed it in right now. More lubricant isn't necessarily going to be a solution. And I think that's a big misconception in the world of lubricants.
Brier, I did want to interrupt there, and just to your point of the difference, we did receive a lot of questions about that, and so I just want to assure everyone that we're going to talk about that a little later in the slides. I did want to ask one question that I received. If you want to go back 2 slides, I'm not sure if it fits here, and so you can direct me if it's better asked elsewhere. But the question just said, are there any medical or natural advances in female sexual performance, such as medications or so forth? So I don't know if you want to speak to that now or if it'll come up later in the presentation.
Literally going to be in like 2 slides.
Yep,
so
perfect. Thanks so much.
No, absolutely. So this is kind of where we talked about medication solutions that have come up in the past years. So when Asfina was, like we talked about earlier, for, again, pain, postmenopausal, I was actually in New Orleans at a sexual medicine conference when this was approved by the FDA. And you would have thought it was Christmas morning because we literally had nothing FDA approved for women for pain. But the very first question, like I said, they asked was, can this be used with cancer patients? And of course, the reps and designers were like, nope, we don't have the research. And now we're in 2022 almost, and we still don't have a solution for that. So that is very frustrating. But at the same time, we know that research is being done and it is being conducted. We're just not moving at the pace we'd like. And then Interosa came out in 2017. And it is a suppository, but again, it has that hormone-like effect and therefore cannot be used with cancer patients. So the person who asked about the vaginal suppositories, this is the one that would have hormones in it, treated for pain. The ones that we talk about suppositories in other ways are strictly muscle relaxers. So that would be the difference in those. And your provider would definitely know that. So this is, again, ADI had came out just a few years, I'd say from 2017, maybe even 2018. That was used to say it was almost like the female Viagra. There was tons of advertisements for it at first. The issue is that you had to sign releases by both your pharmacy and your provider that you would not drink a single drop of alcohol if you were prescribed it, for the fact that it absolutely dropped your blood pressure to sinking levels. What we now know is that research was conducted first thing in the morning. It also was conducted with men, which made no sense to me because it's a female medication and men metabolize alcohol differently than women. And so secondly, what we see now is, yes, you could have a glass of wine out with your partner, you could have your drink at football, and it's not going to have that same effect. Now, again, I'm not a medical provider. I'm telling you what the current research has shown us. Also, what we talked about, that definition of sexually satisfying event, 1 time per month. So you had an increase in libido 1 time in the month of taking this medication. The joke many of my clients will say is, I'd rather have the 3 or 4 glasses of wine on a weekend and more likely be in the mood than take a medication every day that may give me that effect. Not the best answer we want to hear from people, but understanding that there's a lifestyle difference versus, is this medication going to actually work for me? This is more a medication that's come out that actually we have seen more positive effects with. This actually works with the chemical brain system. So like an antidepressant or anti-anxiety medication would work to balance out that increase in dopamine and give you kind of that lowered inhibition, which is what the alcohol does for a lot of people. Problem is, it's an EpiPen. It has to be injected into your abdomen or thigh 45 minutes before sex. The sex therapist in me says, who the hell wants to have sex to inject themselves with a needle 45 minutes prior to intercourse, or any form of play in that matter? At first, that's a hard thing to swallow, but my clients who have taken Valizi have actually said it's not as bad as it sounds. It doesn't seem to be painful. I personally like to get my hands on one so I can actually see it and even try it myself, just so I can have a better idea of what it is. But again, the psyche over the body, if I do this and it's going to increase this, okay, it doesn't tend to have a lot of the same side effects that, again, some of the other medications do as well. So we talked about the lovely big things for ED. These things have been around for a while, but they're also complicated for the fact that they can actually increase erections to last much longer than wanted, and therefore actually end up in urgent cares or EDs if we don't have that ejaculation response or give it time to come back down. I also have a client that says it's almost like paying for sex every time he wants it because it's $100 a pill. So, okay, every time you want to have sex, maybe your partner will be in the mood, maybe they won't. But to roll the dice, I'm going to take this medication and then maybe be out $100. And that sounds not like a negotiable conversation people want to have, but is important if medication is needed on either side.
I do have a few questions in the chat box. So I think, so it says anything for post-menopausal. And then the next question also says the Vyleesi says it's for premenopausal women. Is there anything, I guess that's the same question for menopausal women.
So again, what we're seeing is as much as those are what they're FDA approved for, we do see them used sometimes crossed over. So I do have, again, non-estrogen positive cancer patients who use Asfina, who are not quite menopausal, because menopausal state is this weird middle ground. We have this perimenopausal space versus post and pre that look different. And this space is getting more gray as we know that hormones are functioning differently and we're knowing more and more about them. So it's a good question. I always say that it's really based independently person to person with your provider who's comfortable or not. Again, talking about that. And if we have to rule out that there isn't a medication that falls under your very like distinct situation, this is where we talk about blood flow. We're going to talk about, again, different arousal devices to help with that if the medication route is not working. So it really is an individual based treatment. And again, it's hard because when we talk about sexual medicine, so many things are used off label that are not FDA approved for this, but we use it for that. Wellbutrin, the medication used for antidepressant and anti-anxiety, actually has a counterbalance to, let's say you're on Lexapro for depression after your cancer diagnosis, and you're having erectile issues or arousal issues. Sometimes we add Wellbutrin. The medication chemically actually decreases the sexual side effects. And people are like, you're going to give me a second antidepressant to counteract my antidepressant. That's exactly what we're going to do. So again, it's so convoluted and so confusing. No wonder people are like, I don't know what to do. Yeah, arousal devices, we really work on, you know, if you were to go to any sex toy shop online, there's a million products because it is still a billion-dollar industry. Sex sells. And so you can go and look for a vaginal stimulator, clitoral stimulator, and you're going to find hundreds and go, I don't even know where to start. I can help with that. That's a direction I can help with clients, giving them a place to start small or like, hey, Brier, I've tried da-da-da-da-da and I need a new outlet. Let me then talk you through what are some of the more advanced products. So again, the bullets are the ones on the right and left. Those are usually where we tell clients to start. They're not inserted. They're used just strictly for external play. So they can be used though on your neck, your clavicle, the testicles, around the penis. There's all these types of things vibration can be great for. And then there's things, we talk about self-stimulation. I work with a lot of clients who either personally, religiously, spiritually don't engage in masturbation or self-exploration. It's totally fine. We work within that. We do sometimes try and push that boundary of calling it self-exploration. It's maybe not a goal of orgasm or a goal of even sexual pleasure, but blood flow. Just like you would have physical therapy in a hospital room post-op knee surgery, why not treat the vagina and the penis the same way with increasing blood flow to those organs? Because again, desensitizing, these are sexual parts versus these are just parts of my body that have been affected by a medical treatment. So again, kind of changing that. And I've worked with a lot of different religious organizations and individuals who can absolutely back that. The one device all the way on the left is called a womanizer. That's a horrible name for it. I don't like it at all, but now there's a million different of them on the market. Basically just like the penis pump for men with erectile dysfunction, which again is basically inserting the penis shaft into the device, pumping it full of air, and then constricting those blood vessels and constricting it at the bottom to sustain an erection. It's one of the easiest and less complicated formats for erectile dysfunction to use. What we found out with Science for Women is this little white part of this device is placed directly over the clitoris and is used for suction versus vibration. And so it's basically a little vacuum for the clitoris, similar to the penis pump for the penile shaft, because the penis and the clitoris are made from the same tissue. People don't like to know it, but the clitoris is like a baby penis when it comes to tissue. And so therefore it's amazing. It took us this many years to figure out devices that would work the same way. These type of clitoral stimulators absolutely do that. So again, going back to medications haven't worked, Brier. The lubricants I've all tried. I've done the vaginal moisturizers. This is our next step outside of pelvic floor PT. We'd want to get blood flow back to that part of the body. So a lot of these devices I suggest to clients not to use like maybe in couples play, because they really do have to kind of be stabilized. You can 100% use them that way. But we close clients like maybe use it 5 minutes before you take a shower, 5 minutes after a shower where you have some blood flow and your body's maybe a little bit more relaxed, just to retrain the brain and body to connect that blood flow can go to that area. Because again, without stimulation to the clitoris or the penis itself, blood does not flow there on a natural basis, just enough to keep the tissue healthy. Otherwise, there isn't stimulation to those areas, therefore blood flow isn't to those areas. So just something to kind of think about, that blood flow is super, super, super important. And we don't really necessarily think about that when things aren't working topically or medically. OMGS is also a website that's run by clinical research to teach women how to self-explore stimulation due to the fact that we live in a culture where women are not supposed to touch and men can. Therefore, it's just a safe option if we're really in left field what to do. Vaginal dryness. So we talked about lubricants, dilators, vaginal moisturizers, different kinds of touch, like I said, stimulating other parts of the body, and PFPT, and then Kegel's bringing blood flow to those areas. So again, and if you're into coconut oil, which was a huge craze when keto came out, you can buy coconut oil in the grocery section, way cheaper than buying it in like the beauty section, and it's the same stuff in a different bottle. So we talked about vacuum pump. Yeah.
Brier, I did have a question that was submitted and on the topic of vaginal dryness, and it just says, for women's underwear, is there a type of material that is better for someone that's experiencing vaginal dryness, such as cotton, nylon, microfiber?
100% cotton. It's one of those things, if we have vaginal dryness, we have that sensitivity to the tissue. We want to remove all dyes, perfumes, 100% cotton underwear. It's kind of, and again, going back to the most natural basic space we can be. So a lot of people think, okay, I'm doing all these things, but I'm still using, really performed laundry detergent on this cotton underwear, could also be causing some of that discomfort and friction to those dried tissues. Soaps, things we use in our showers, lotions we put on post-sex, these are all things to pay attention to. And again, men also have tissue issue. And so same thing of being really aware of the other parts of our body that we're using products that could also be agitating it. But yes, cotton underwear is 100% where we suggest starting.
And I received a question just now that says, does coconut oil cause yeast infections?
Always a good question. And again, it's one of those things, it depends where a person's pH balance starts. Everybody's bodies are so internally different. Same reason more women get, bacterial vaginosis, certain women get more UTIs. Anatomy, where your tissues start in the first place, is going to have a massive effect on that. So what we tell clients is, if that's a concern, we know that we can treat yeast infections. They're transitional, they're not permanent. If you want to try it and see what happens, then you kind of know you're going to rule it out. Same thing, like I said, if you really like the heating lubricants and you don't have any problems, okay. But if you've never tried one and you do, and you're like, oh, this does not feel good, and now I have some bacterial infection, then we know we should probably stay away from those products that have that in it. Again, I hate to say we have to kind of find out it doesn't work before it works. This is where that's a lot safer to do than that controversial of somebody asked about, one provider says that DHEA or topical estrogen strictly to the vaginal opening is okay, versus another provider is like, absolutely not. We're not going to do that. And it's like, what do we do then? We're in the space where these are the people I'm supposed to trust, but they have two very different spaces. And I know this with the medical providers I work with here. I've had oncologists who are okay and ones that aren't, and they've told the same person this. And I have that client coming back to me going, I'm confused. And I have to tell them in the end, I can't make that decision for you, or is that my space to do that? But we can talk through where your concerns are and what questions to ask, and then make that decision. There are some women that I've worked with who are saying, yep, I want this back enough that I'm going to play roulette. I was like, okay. And I have other women that are like, nope, that's not where I'm at in my life. I don't want to take that chance right now. Okay. There's no way of knowing. What I do tell women though, is I think that something that isn't talked about is a lot of women take testosterone for low desire issues and don't realize that testosterone can be converted into estrogen in the body. So even though you're applying testosterone on the external, even using testosterone, for just vaginal clitoral stimulation type, we don't talk enough that can happen. And I think that's really important for women to know. Again, I'm not a medical provider. I'm strictly providing the research that I've clinically came across and spoken to medical providers about. But again, controversy is people fall on both sides of the fence. So I hate to say.
Thanks, Brier, for touching on that. We did get a lot of questions on that topic. So I think it's something that people have questions on. So are there any medications that are able to be prescribed for vaginal dryness?
And in essence, again, not necessarily for the dryness itself. We do use things like lidocaine topically, which will sting when applied to a dry tissue, but the numbness that can come across to those nerves and the tissues will allow for penetrative play, sometimes enough to take the pain trigger down enough to increase the pleasure triggers. Because again, they run on the same neural pathway, which is why if you're having pain with sex, male or female, you're not going to experience pleasure because they run the same path. But if we can reduce the pain, we have a potential to increase pleasure. And so topical lidocaine is used predominantly for reducing that tissue discomfort. But yeah, that's the only really prescribed dryness that I can think of outside of those over-the-counter vaginal moisturizers. And then, like we said, the suppositories. So yeah, again, it's a field that just doesn't have enough clinical research for medications yet.
Thanks, Brier.
Yeah, no problem. And so if we know that the penile pumps don't work for erectile dysfunction, we have penile injections. This is where I tell women, we say all the time, women, gosh, we have it so much worse. We deal with periods and we have to deal with these internal things that we can't change. I would not want a needle stuck in my vaginal tissue. There's the key though. There is vulvar injections that can also treat vulvar pain, and even muscle injections to treat the muscle directly with Kenalog or other types of numbing agents to reduce that. Even Botox has been used injected into the muscles to release those muscles. Again, secondary side effect can be fecal or urinary incontinence. So again, play out all the options, take in everything that you can, and then really decide. But yes, there are definitely penis injections for men who can help with those erectile functioning if the blood flow alone isn't working. Same thing with pellets. Pellets can be inserted into the urethra to, again, allow those tissues to come to some calmness. But again, there can be the side effects of burning and urination prior to insertion. Penile implants, same thing. If none of this is working, we're going to just replace it. This would go the same thing with breast reconstruction. We replace the tissues with products or devices that can help with any type of body image issue or confidence. And penile implants, again, definitely are not used as often because they're the last resort for men, but absolutely will sustain 80%, actually stay erect all the time, but they are taught to tuck in a waistband. But then they always know that they're available to have a full erection for penetrative play that does build that confidence back.
Brier, I did receive another question on the vaginal dryness, and it was just a question of why does breast cancer affect vaginal dryness, if you're able to speak to that?
Basically, it's that mentality that vaginal tissue is fed by estrogen. And so, as we know, estrogen basically makes our tissues healthy, which is why we talk about tissues in our 20s and 30s tend to be healthier. And then we hit what we consider perimenopause between 32 and 35. And then we start to get this decline in estrogen naturally. But if you have breast cancer, we're going to remove that estrogen, most likely that it's estrogen positive immediately. So that's where we talk about chemical menopause, which means your tissues one day go from having all their healthy loveliness to them, and then the next day it's gone. And so we don't get anything back unless we put it back in the body. And so vaginal atrophy is one of the most common things we see with chemical menopause due to breast cancer, is usually an automatic removal of estrogen. So again, we talk about tamoxifen. Some women have libido with tamoxifen. And other women talk about my libido's gone. My, hormones are now officially, working out, and everything has shriveled up. And that's basically the tissue without the blood flow and estrogen in it. They literally get brittle, almost like tissue paper. And that's where we get the microscopic cuts that can happen with any type of play or touch that the lubricants and vaginal moisturizers can help, but aren't going to be able to heal it without that estrogen. So those are the hard pills to swallow, that the acceptance is that's what's happening to the body.
Thanks, Brier. That was really helpful. I have another question that's related to that. It says, after cisplatin radiation and a total laryngectomy, I have no libido, absolutely none. Is this a usual symptom?
Yeah, we talk about with any of the cancers, a change in surgery radiation is going to change the way your body feels. It's that disconnect of what I know about my body, even if you had really good mind-body awareness. And if you didn't, you're going to now, because everything's in your face and you're really present about it. And libido is multifactorial. It is physical, it is hormonal, but it's also relational, it's psychological, it's spiritual. And so with libido, we try and treat it from all facets. If we can't treat it physically, because the medical issues are not allowed due to whatever the cancer was. I'm
gonna go take my shower. You want to finish listening to this for me?
Redefining and restructuring. But yes, that is totally normal and expected. But again, we don't talk about with certain types of cancer that that's going to happen. We think, again, prostate and breast are kind of the big ones that people talk about, cervical cancer too. But no, any form of cancer is going to affect the way you feel about your body. That's where, again, restructuring your sexual expectations are going to come in pretty highly. So I'm going to fly through this stuff. So sensate focus, again, is a technique that we use to train the brain and body that it doesn't have to just be penile vaginal sex or intercourse or penetrative play. Sensual touches, ways to caress each other can absolutely help a couple become more sexually intimate. If again, then we prioritize that we can do just this and it's not a form of just foreplay. Types of touch are just as important. Affectionate touch, a hug, a kiss, a cuddle is just as important as an erotic stimulation for lowering the body's inhibition and feeling connected where the muscles will relax. A 5-second hug to 30-second hug actually starts releasing oxytocin, which makes us feel the cuddle hormone. It makes us feel warm and fuzzy. And we need more of that when we're dealing with that anger and the frustration of the changes. So we say that can happen from a cat, a dog, a hamster. So it doesn't have to be another person. If we're in a single relationship in our life, we have options to release oxytocin, even if it's not with a sexual partner. Again, sex equals intercourse, horrible social norm that we have. Biggest thing we work on as sex therapists is that is not true. We can absolutely have a healthy sexual relationship without intercourse of some kind. It's just a facet of it. So again, I did not have sexual relations with that woman was a quote from a prominent person at one point in our history, AKA President Bill Clinton. This whole Oval Office incident. Going on national TV and telling people I did not have sexual relations with a woman because I did not engage in intercourse, we kind of say is BS. As therapists, we really state that hugging your intimate partner, you hug differently than your kid or your friend. Kissing your partner is a different kiss than you give your kid or your partner or your friends or whoever. So any form of sexual relation with your partner is a form of intimacy and a sexual relationship. So Bill Clinton and I would have to differ on our definitions of sexual activity. Again, how do we redefine it? Kitchen talk. Worst thing couples can do is talk about sex in bed, naked, or potentially being naked. It causes way too high of anxiety for couples. So I say, sit down at your kitchen table, talk on your way to the grocery store, somewhere where there is no chance to necessarily be sexual at the moment, so we can have the anxiety come down about what are our options. Talk about your treatment protocols. If you're talking about, to decide to use that hormonal topical agent and you have a hormone positive cancer, I probably wouldn't talk about that in bed when you're in a really vulnerable space of really wanting to have that sexual response and not getting there. I would have that at the kitchen table, fully clothed, in a headspace where you can feel a little bit more clear. Normalizing the grief, sexual scripts have to change. Establishing a new normal. Again, it's an acceptance, not an agreement, and the role change. We can have a lot of guilt and shame in the role shifts from a partner becoming a caretaker as well as an intimate person. And there can be the covert and overt resentment. Partners, again, be aware they're also going through a stage of adjustment. And I think these individuals are very much overlooked. It's the main reason actually I got into the cancer sex world. One of my best friends was diagnosed with, his wife diagnosed with cervical cancer, or I would say girlfriend at the time. And they were in their mid-20s. So he called me up in the middle of the night crying because he didn't know what to do about it. And at no appointment did anybody adjust his or talk to him about the adjustment he was going through. So I just think that's really important as a couple to, you're in this journey together. Venus, same thing. I'm a huge advocate, non-penetrative sex, practice it, try it, do it, see what happens, see how we can connect on those different levels in other ways, bathing together, showering together, eating food off each other, scene out of any funny movie, Hot Shots, great movie, with Charlie Sheen when he was not crazy back in the day. Mentality of do something different. Single, again, like we talked about, there's a lot of talking about how to be open, being assertive with what you need sexually is not easy for men or women. And so being direct with new partners when you're ready, communicating about the physical limitations. If that is vaginal dryness and we have to use a lubricant, I'm an advocate. I don't care if you're 21 having sex or you're 81 having sex, lubricant should always be part of your play. It just takes an edge off of that anxiety. And how do we address these issues? Again, it's healthy, it's normal. Please, please, please talk about it. It's why you're all here. So I'm glad. These are all the benefits of sexual play, not just intercourse, which we know can make us all feel better. We sleep better, we feel better, we burn calories. It's good for our heart, boost immune. How come we're not addressing this? Biggest thing I want to talk about on this slide is many providers feel another provider will address this issue. We are just avoidant because we sometimes don't know what to talk about. So it's related to that social experiment. If you see somebody being hurt and you're like, call 911, we should call 911. Everybody thinks somebody else called 911. So they actually say if you're in trouble, you should yell fire because people tend to pay more attention if somebody yells fire than help. But also the mentality is it's okay to ask because you saw something. Big problem at the bottom is almost 43% of medical schools do not train in sexual dysfunction. So all these medical people that we go to ask questions to, 43% on average have no sexual training. I teach at ground rounds for OBs in a lot of the major health systems here in town in the schools. And outside of my lecture, many of them don't have education in that. Luckily, it's becoming more prevalent as these issues are coming more up, but many don't have the experience to answer the questions you might have. Healthcare system problems. This has come more to light of as, again, the lifestyles and gender identities and sexual identities have become more open. Again, they've always been there. We're just having more conversations. Healthcare has systemic issues in being able to address those different identities and how to support them. The LGBTQ community has been overlooked drastically when they seek treatment for sexual dysfunction post-medical procedures because people assume it's different when their body functions just like anybody else's, and that shouldn't be overlooked. Being sexually genuine is really hard if you're involved in certain types of communities. My kink clients have a hard time sometimes coming forward with things they want to do and then being able to ask a provider on how to get help for that medically. And then again, we know with polyamorous type relationships, when there's more than two people involved, how does that dynamic look post-cancer treatment? We have very little research, but we know that it's still an individualistic journey and each person in that partnership needs to be involved in the treatment if open to it. Again, how do we address these issues? Most things now in organizations have patient portals. We suggest calling, faxing, emailing, bring something in that is these are the things I want to talk about. Here's a script that we suggest using. Dr. Bolt does a lot of, she's also a certified sex therapist who talks very openly of how to communicate with professionals. And her script is a great way to start. And again, these are just two quotes that I really enjoy as the mentality that sex is part of our overall self And we don't just merely survive, but we work on thriving. And your sexual identity and sexual exploration is a big part of who we are, and that shouldn't be dismissed from us. So these are the two collaboration persons here in Omaha for anybody that's in Nebraska that I work with. This is Dr. Anna Maria Nagy's clinic at Methodist here in Omaha. And then Dr. Melissa Dare has done an immense amount of training across the country and is well known throughout the sex medicine community. And she does actually do consults, I know, across states, because she's actually licensed, I believe, in some other states. So again, vast amount of resources. All these individuals can be found on sexual medicine organizations, as well as ASECT is a nice option for local resources. Okay, and this is my info. If you guys have any questions or additional knowledge or information you need post this presentation. So, all right, Kelly, I'll open it up to you on Q&A and anything we didn't get covered because I spoke really fast. So.
Thanks, Brier. Yeah, and it was a lot of content, but it did cover a lot of the questions that I received in advance. So thank you very much. And like Brier said earlier, we will send out the slides so that you have that. I know we moved pretty fast, but it was just so that we would be able to give out as much information as we could, as well as, you know, cover the questions that you guys had. As everyone knows, I did solicit questions in advance, and I tried to ask those throughout the presentation as Brier was discussing those topics. One of the questions that I did receive in it, and it was just about insurance, and it was about covering the cost. And so the question is are insurance companies still required to cover breast reconstruction and subsequent surgeries to repair, including nipple reconstruction and tattoos? Not sure if you have anything to add to that, Brier, or if you could speak to it at all.
Yeah. So again, I tell clients all the time, I'm not medically trained. I'm not your insurance provider. And we all know the lovely world of insurance is super complicated and makes no sense to anybody. I have 2 kids with autism, and it's amazing what is covered or not. I tell people all the time, if I could quit my job and just be on Medicaid, I'd probably have more coverage for my children than the current group insurance I pay for through my husband's company. So again, I get it's the most frustrating space. But in 1998, the Women's Health and Cancer Rights Act was passed. And so therefore, most group policies are required to cover some form of mastectomy, which again goes then all post-op, even if that's years down the road, which also includes tattoos, things like that, most anything related to the mastectomy itself. The difference is there are certain insurance procedures or companies based in either churches or certain government policies that do not and are not required to follow that act. Again, that's where I said the little complications come in. Some Medicare policies don't cover that. And therefore we talk about if there's a secondary Medicaid policy, that usually does. And so I always say it's a super, super individualistic state by state. So we say work with your current insurance company. Is there's a supplemental that you can add that might cover something down the road? The other one is preventative surgeries are super complicated. Some and a lot of group policies will cover preventative mastectomies if we know we're meeting the genetics, the potential, but there are many that don't, which is again, stupid culturally and socially. If we talk financially, if we can prevent these things, we're actually going to save money down the road along with saving lives. But for some odd reason, those of us that experience clinical difficulties are not the people who make the policies. So it's, trust me, I get on my preach box about this all day long. So yeah, it's a good question, but it's complicated.
Thanks, that's helpful, Brier. And I do have a couple follow-up questions related to that, but I'll just say our event today does go for another 10 minutes about, and so we will open the floor to questions if anybody wants to come off mute. Otherwise, feel free to submit them in the chat box. Like I said earlier, you can do so anonymously by submitting it directly to me, and I'll be sure to moderate that. But as you guys are thinking of those questions, if there isn't anything we haven't covered yet, one of the follow-up questions is a little bit specific, but do you have any recommendations for any good reconstructive plastic surgeons in the Omaha area? That was just one of the questions that was submitted.
You know, a lot of the clients I've worked with have really liked their surgeons at Aesthetic Surgical Center. God, I totally can't blink, but it's
Aesthetic Surgical Image.
Yes, they have massive amounts of commercials, but they actually do have a really well-known breast reconstruction program that kind of really does walk through a lot of the options. And the Med Center is tend to be known to have some really good surgeons. Again, what we tell clients is especially if somebody is marketing themselves as a breast surgeon, does not mean that they have the credentialing or the experience for reconstruction. And it's really important to really ask about that specific.
Okay. The only last question is a little more specific, but it says for complex reconstruction issues, will insurance pay for out-of-town revision if nobody in our area is available? And you kind of spoke to that, where it really is the insurance that will be able to specifically answer that. But the participant said, can they have their surgeon of choice? So I think you kind of answered that as well. But if you have anything else to add, I'll open the floor.
Again, if their group policy is covered under, if mastectomy is covered under it in a group policy, that lovely Rights Act will kick in. And if there are no providers, what we have been told, and I treat a lot of rural individuals, Zoom has been great for that for us as sex therapists, because in the state of Nebraska, west of Lincoln, we don't have anybody. And so that's like 9/10 of the state is west of Nebraska. So we have been able to treat individuals who, can't come in. And I have plenty of clients that literally come in, see their PFPT, me, and their medical provider all in one day. And then they only come in like once every 3 or 4 months because they can't come in weekly or bi-weekly due to the distance. But with that being said, what I have seen is even with those policies, insurance doesn't usually cover somebody out of network. And so usually if you have to go across state lines or to another space, insurance might tell you that we will be the one picking your physician. So.
Thanks, Brier. Are there any support groups or therapy for women seeking help with relational or sexual or body image issues? I know obviously that's your profession. So perhaps you could speak to the point of the support groups, or like you said, if somebody's not from the area and they're attending, I know we have several people from out of state. You mentioned this ACP as a network, and I think you said earlier to just reach out to you, or is there a general directory that would be easy for people to do that?
Yes, ASECT is it's AAS.
Oh, sorry.
Nope, it's okay, no worries. Trust me, I get it all the time. Yes, ASECT, like I said, is worldwide. And so you can go to their website and it says find its directory, membership directory, and you can find sex educators, sex therapists. And what we suggest doing is contact those sex therapists or sex counselors or educators in those areas, and they will have that information locally. Here in town, again, Time to Heal is a good one. They do have ongoing support groups off and on, I know of, as well as Project Paint is very well known here in town as very supportive to the community. But again, COVID has really affected this to move these to Zoom, but even then has been difficult to keep going. So I know some local groups have also kind of taken a break since COVID, which is horrible because that's when we really do need it. And they're just really transitional depending on therapist availability and space actually too. So it is an ongoing question for sure.
Yeah.
And definitely needed.
Thanks, Brier. I'll go ahead. So this week, what I'll do next week is send out a link to this recording, the slides. I'll also go ahead and send a link to the directory that Brier just mentioned, where if you are from a different state or locally, you can go on and see that directory. I think that's the question that was asked. It says, what was that group and website name? I will go ahead and include that in my follow-up email, but in case that wasn't the question, the intent of the question that was asked in the chat box, please correct me. I did receive another question that says, what's a good reputable online store for purchasing sex toys and lubes?
I get this all the time. So the resource list that is sent out has Adam and Eve on it, and My Pleasures are both organizations. My Pleasures is still, again, marketable to everything. So I still be cautious what you're going on to, know what you're going to be exposed to. Not everybody's ready for that kind of exposure. But My Pleasures has a chat that is actually run by people that we know. They're educated. Some of them are sex educators, certified sex educators, to walk you through. If you've never purchased an arousal device, you have no idea where to start. They're a really great website that has even, a template to say, hey, you're new to this. Here are some questions to ask yourself. Adam and Eve actually are one of the bigger sponsors for us as sex therapists. Again, none of us get kickback from them, but they've been around since the 1970s and are really reputable to the products that they sell. And again, supportive of our research and industry. So they tend to do a lot better work than some. And again, I know it can be scary because it could be somebody selling stuff out of their mom's basement or the backseat of their car. But those are the two sites I usually have my own clients start with.
Thanks,
So-
Brier. Anybody else have any questions while we have some time? You can submit it in the chat box, and you can come off mute also if you're comfortable doing so.
On the last 3 slides, you, besides yourself, you share resources. So all of those 3, including yourself, it's just like that we can go check and maybe schedule an appointment or.
Absolutely. Absolutely. Both. And again, I tell clients, like, because there's so few people trained in this field medically, Nebraska, again, because we're a little bit more of a conservative state than some, you will find more sexual medicine providers on the coast than here in our state. But at the same time, yes, they're all trained usually by the same major organizations. Like I said, Melissa Dare has done cross-country training with some of the top people in the country in our field. What I tell clients is Melissa's a little bit more progressive, and Nagy's a little bit more conservative with her treatments. And so sometimes I say, come contact me with a quick paragraph of where you're at and kind of your hesitation, and I can kind of direct. But both are really good and trained in their own ways. And I've both worked with personally. We used to all work at Methodist, and then we've kind of, due to family dynamics and some certain situations, have gone separate ways. But yeah, we still collaborate and speak regularly about client care. So,
And you also take patients, new patients.
I do. I'm not currently taking new patients just because the COVID had made my life and my clients a little more on edge. So my caseload is currently full. I'm actually not probably even opening that till February, but what I am doing again is helping clients find resources, either if that's reading materials. There are through ASEC, there are at least 4 other sex therapists in the state of Nebraska, all located here in Omaha, that do also fluctuate with taking on new clients. So I can also, anybody that wants that list, I can send you the list of sex therapists here in town that also have different approaches. You know, we're all trained and certified by ASEC, but we all have different approaches on how we do things.
Okay.
Yeah, I wish I could tell you yes to that, because I would treat as many people as I can, but I had an unexpected 3rd child come in my life, and my 2 children with autism. I have 9 therapies I have to attend a week between all of us. And so I would love to work more. I'm a workaholic and love what I do, but yeah, reality has changed that game a little bit.
Thanks, Brier. I did get a request, yes, to please send the list. So I'll connect with Brier on any follow-up resources. And like I said, I'll include all of those in a follow-up email to everybody. It says, what was the second name of the vendor for finding lotions and toys besides Adam and Eve? I think My Pleasure.
Pleasures. So it's on the resource list. The very top of the resource list will have those online locations as well. If you're here in Omaha, the stores, Adam and Eve actually has a brick and mortar here in town. They have many locations over the country. Again, if you're open to it, I suggest going to a store. And like I said, maybe contact a sex therapist in your city and ask for the reputable stores that they work with. Because if you can touch, they usually have these products open so you can feel the textures, you can see the vibrations, because sometimes you'll pay $30 for a vibrator to come to your house to use only externally, because we're maybe not ready for any type of internal play and we don't like the texture or it's too strong. And you know, it's a good thing that sex toys can't be returned. So bad thing that you spend money on things that you're not going to end up using. Like I have in my office, and a lot of sex therapists in their office will have different products so you can kind of feel them that way. Then like I have the set of dilators that I showed you a picture of, so you can feel what that, you know, looks like.
Thanks, Brier. We did get a comment that said, thanks for an excellent presentation. And I'll just echo that. I think when we solicited questions, a lot of the feedback that I got in my emails was, this is a vulnerable topic and people don't talk about it. So I really appreciate your willingness, Brier, and coming and presenting today. I think this has been really excellent. It's been very informative, and I'm hopeful that we got everyone's questions answered. So I think at that, we'll probably close up. I'll end by just sharing a couple announcements. For those of you who haven't attended one of these in the past, we do host these every month on different topics. And so stay tuned for upcoming event announcements. I know in February, we're going to do a topic on talking to kids about your cancer, having age-appropriate conversations about your diagnosis and what you're going through. So we will have our list of events up on our website as soon as we're able to finalize some of those details. But I would just say, if you guys have any topics that you would like to be covered, things that you'd like to see us bring in a presenter, a speaker to talk about, please feel free. You have my email me. You can call our office. We always take suggestions on different topics. In addition, we do have a 9-week Survivorship 101 class. It's just a class that talks about cancer survivorship. It talks about different topics such as nutrition, relationships, side effects, and so forth. And so if you're interested in that, also just check out our website or reach out to me directly. I think at that we'll close up. I have another comment in the chat that says thanks. So yes, thanks. Thank you so much, Brier. And thanks everybody for joining us. I know this is an important topic. Another person says, great presentation, thank you. So lots of love in the chat box. But if you guys have any follow-up questions, feel free to reach out to us directly, reach out to Brier, and we'll connect you with the right resources.
Yeah, and I just want to say thanks to all of you real fast. Like, just coming shows me that people care about this topic, and those of us that really push this, like, we couldn't do this if we didn't have people to listen. And again, as a therapist, doctors don't always want to hear us because we're therapists and we kind of get put on that second tier of care. So please, if you feel vulnerable up to it and are pushing yourself, like, bring these things to your physicians, bring these things to your social workers and your nurses, because it really is important. The more that we can openly talk about it, it won't be so scary. So I really, really appreciate you all being here this morning. And thank you, any of you that were going to be here in October or not. Appreciate that too. So thank you so much.
Yes, thanks everyone. Another comment that said, thank you for answering my questions. Great presentation. So thanks to everyone for joining us, and we'll see you next time.
See you guys.